measure amplitude with peaks from cornea, from posterior and anterior capsular lens capsule, and then we have the peak from the retina. We use it to measure axial length, anterior chamber, lens thickness, etc. This is done for IOL calculations and estimating internal echogenicity. B mode is the 2D imaging in the grayscale, which allows us to locate, measure, assess borders, shape, and so on. We use B mode to check for retinal detachment, intraocular foreign bodies, tumors, important, lens subluxation and luxation. For example, after cataract surgery, if we have dropped nucleus, vitreous hemorrhage, posterior scleritis. This is very important because posterior scleritis is behind the visible part of the eye and can mimic other conditions. Also diseases of the choroid, for example, choroidal detachment, inflammation, and endophthalmitis. With high expertise, the person doing the examination can detect macular edema, optic nerve atrophy, orbital masses, and inflammation, including the lacrimal gland, extraocular muscles, so we can measure them, for example, when we suspect either myositis of a certain muscle or in thyroid-associated orbitopathy. This is how it looks. As we said, we have peaks from cornea, lens, and retina. This is the B ultrasound with the A ultrasound combined, and we have the low internal echogenicity of the melanoma. What are some questions? I think we may have gone through some of them, but when would we use A mode? For cataract, melanoma, or corneal ulcer? It's for cataract usually, when we want to remove the cataract and calculate the power of the intraocular lens that we are going to implant. When is B mode a method of choice? You have to remember that B mode is used whenever we have opaque ocular structures, for example, a vascularized leucoma of the cornea, or total cataract, or melanoma as well. And pigmentary retinitis, we would not use B mode because there is clear optical parts of the eye, and we have problem with the cells in the retina. So if we have this, I think we did this question. If we suspect metallic intraocular foreign body, we would do B mode ultrasound. We talked about fluorescein angiography. We have the brachioretinal time, choroidal, arterial venous phases, and the venous phase can be divided into three: early, middle, and late, and the late tissue phase. This is here the way that the fluorescein comes to the ophthalmic artery. As we said, first branch the short posterior ciliary arteries, which provide the choroidal circulation. That's why we have first the choroid flush, and then we have the central retinal artery. That's why the arterial phase is second to choroidal phase. So here is the choroidal phase. You can see the patchy flow in the choroid. Then we have the arterial phase. We have brighter arteries and dark veins. We have the arteriovenous phase when we have flow in the capillary bed, and as you can see, we have some laminar flow in the veins, which means this is the moment, the start of the early venous phase between the arterial venous and early venous phase. This is the early venous phase, which is very important because we have this laminar venous flow of the dye. And if you have, for example, hypertension and hypertensive retinopathy, you can see the turbulation of flow when the sclerotic arterial wall presses down on the vein. We have the mid and late venous. This is not very easy to discern, but you have venous phase when the veins are completely filled in and have an intensive glow. And this is the late tissue phase. You have to remember that the optic disc and sclera they typically are hyperfluorescent in the late phases because they absorb part of the dye. So how do we assess our angiogram? We have normal, abnormal, we have artifacts. Abnormal angiogram includes hyperfluorescence and hypofluorescence. Hyper is when we have more intense light in normal parts, or if we have fluorescence where usually we don't have such. And hypofluorescence can be blocked when you have some kind of, for example, blood or pigment, and non-filling defect of filling, which is when we have obstruction in the vessels. Hyperfluorescence can be divided into leakage when we have leakage from vessels, usually a new vascularization. We have pooling when we have a cavity. We have staining when we have, for example, these deposits in macular degeneration, the drusen. And transmitted hyperfluorescence, this is when we have lack of pigment epithelium and we see only the choroid light. So here it is a window defect or transmission defect. This is observed in parts where there is no pigment epithelium. This is a disease of the pigment epithelium. On fundus autofluorescence, it looks dark because the autofluorescence in the retina is made possible by the pigment content in the pigment epithelial cells, lipofuscin especially. And whenever we don't have a pigment epithelium, it looks dark. And then we do the fluorescein angiography, and here we see more this hyperfluorescence, which is characteristic of this is the choroidal, normal choroidal fluorescence, which is not masked by the pigment epithelium. Here we have a diabetic patient where we have all kinds of hyperfluorescence. We have, for example, hyperfluorescence of the microaneurysms, these tiny little dots. The bigger dots are staining of exudates, and then we have this intense hyperfluorescence, which is leakage from new vascularization. The leakage usually persists in the late phases, so that's why you can say it's leakage. It persists in late phases, it has undefined borders, and it grows. It becomes bigger and less clear throughout the angiogram. This is something I wanted to show you, how to identify retinal imaging. So we have color fundus. This is the typical fundus that we can see also with the ophthalmoscope or indirect ophthalmoscopy. We have red vessels, we have the yellowish pigment surrounding the macula and the increased reflex in the fovea, and the optic disc, which is pale pink. Then we have the autofluorescence. As I said, autofluorescence is determined by the content of pigment in the pigment epithelium cells. The vessels and the optic discs are black because they do not have pigments, and the fovea also is black because there is other screening pigments in the cells there. So fluorescein angiography, we have vessels that are white. In the late phases of the fluorescein angiography, as we said, the optic discs become white also, and the fovea is dark. This is due to the high content of pigment, as well as they have a lot of melanin granules here in the fovea, and also there are no vessels in the fovea. This is the foveolar avascular zone, which is very important for diabetic patients. If you see that here in the fovea there is fluorescence and it appears bright, then the diabetic patient has problems. Red-free photo. This is also very important. We have a white disc with dark vessels and dark fovea. This is important because it marks retinal nerve fiber layer here, these reflectances that are more whitish or grayish, and also it can make more visible microaneurysms and small hemorrhages. It's more clear. Then we have the infrared reflectance, which is before we inject the fluorescein. If we make a photo of this of the fundus before the injection, we have this picture here. We have dark disc, dark vessels, and gray fovea. And then we have the indocyanin green angiography, which is a different method for visualizing the vessels in the retina, but this is more important for choroidal circulation. So, hypofluorescence, here we have a defect in filling. This is capillary non-perfusion. So here the dark zone means that there are no capillaries in these zones. This is a terrible condition with very low visual acuity and almost nothing we can do about it, because these are cells from neurogenic descent, and they are very sensitive to hypoxia. And when there is no blood flow there, they die out very quickly. And this is something we have to be mindful of. And if it is outside the macula, we have to do laser in these spots where there is no where there is capillary non-perfusion to prevent neovascularization. This is very interesting. This is also diabetic patients. This is called corona circinata. These are exudates that are situated around leaking microaneurysms. Here we have staining of the exudates, but also leakage from the microaneurysm that led to the formation of these exudates. And here, of course, the retina is thickened and we have edema. Here we can do focal laser only in the zone of the leaking microaneurysm, and then we will have resolved this problem. This is a diffuse macular edema where we have a lot of hyperfluorescence and a little bit of blocked fluorescence where we have hemorrhages. This is a very interesting disease. This is the central serous chorioretinopathy. called the smokestack leak. So this disease is caused by a dysfunction in the pigment epithelium, which leads to an improper function of the pigment epithelium and its ability to pump out fluid from the retina towards the choroid. Here it is the defect of the pigment epithelium. It starts to fill in and then it goes upward because this is like a bubble over the retina, under the retina, and it starts to fill in and becomes this mushroom form in the end. If it persists long enough, it can fill the whole cavity. Here is a very interesting case. This is one of our cases. It's a kid, I think around 10 years old. This is an early arterial phase. And here we have some hyperfluorescence in the macula. In the early stages, this is a transmission defect because we do not have pigment epithelium in this zone. This is early venous phase. Can you tell me if something makes, it seems important to you? What's different than the usual angiography? Do you hear me okay?
Yes.
Yes. Okay. So can you tell me? Does it look different than the other ones, except the macula, which I already said? Does it seem darker to you, for instance? This is the first phase here. Look how dark it is. It's the symptom of dark choroid. This is very typical for Stargardt's disease. And here, except that the choroid is dark, we have this transmission defect that is very typical for Stargardt's disease. Here is the other eye, it's almost the same, and the choroid is still dark and remains dark throughout the whole angiography. Okay, so questions. We already covered the first questions. What is not actually hyperfluorescence? What type can be accepted?
The first one?
Yes, defect in filling. Of course, this leads to hypofluorescence, so less fluorescence. And what can cause blocked fluorescence?
The last one?
Yes. Okay, so OCT, as we said, application, we have retinal diseases like macular hole, vitreomacular traction, pigment epithelium detachments, optic nerve pathology like glaucoma. This is very important. Nowadays, glaucoma is diagnosed by OCT. All kinds of optic neuropathies like ischemic optic neuropathy, and of course anterior segment optical coherence tomography can give us information about cornea, the anterior chamber angle, and the anterior chamber contents if there are cells, for example, from inflammation. It is not applicable in cases with opacities, so glaucoma, cataract, or vitreous hemorrhage, and of course it's a little bit more expensive than, for example, ultrasound. Here is again the structure that we get from this imaging, the choroid and all the layers, with here the interdigitation between pigment epithelium and photoreceptors. The outer segments and inner segments are different, have different reflectances, and the the link between the inner and outer photoreceptors is also a different layer because there, as I said, are more organelles. So this is another one of our cases. Can you tell me what the yellow thing here is? How do you call this?
The macula. Do you mean the bits on the outside?
Okay. The yellow thing, the big yellow thing in the middle, what is this?
It's the macula, isn't it?
Dry macular degeneration.
This is called an exudate. The yellow things in the retina are usually exudates. The drusen in macular degeneration are also a little bit yellow, but when you do the OCT, you can clearly see the difference. But this one is a big one. It's a really big one. This is a great exudate, and this is a very interesting disease. It's again in children. This is Coats disease. We have changes in the vessel wall that leads to leakage of serum and blood components in the retina. This picture here is before treatment. After treatment, this exudate was almost completely resorbed. We did some laser of the leaking parts, and the condition improved dramatically. But this is Coats disease. You will speak about this in your retina lecture. This is again one of our cases. What would you say on this OCT that we have? It's pretty clear. Maybe I will make it bigger. Okay, so we have cysts here that are filled with water. This is macular edema. We have also an epiretinal membrane. And if you look at the color photo, you can see that the picture is not really clear. This is not an artifact. This is a condition called vitritis, inflammation in the vitreous cavity, which is, as I said, could be the reason for cystoid macular edema in the macula on OCT. But you should always look at the ophthalmoscopy and check for vitritis, because here from the OCT you cannot say that this is inflammatory. You can only say that we have macular edema. This is cystoid macular edema in diabetes. You can see you can have fluid under the retina, in the retina, with giant cysts and even formation of great cavities. You can have this one. This is called schisis, retinoschisis, because there is a lot of fluid and the whole retina is stretched. This is a picture that we already saw. We have the dry AMD where we have atrophy, and the wet AMD where we have hemorrhages. Here it is a subretinal hemorrhage. This is one of our patients. I think this is also macular degeneration. As you can see, the outer layers are very wavy, and we also have fluid under the neurosensory retina and some exudates. So OCT can be used in all except this is an easy one.
Cataract.
Exactly. If we have a total cataract that is not transparent enough, we cannot do OCT. And which is true for OCT.
The latter.
Yes. Because most of the patients have concerns about the technology, if it will somehow harm them, and they think it uses X-rays, we have to reassure them that this is a completely safe procedure, that it only uses light and is not a source of concern. As I said, the optical scan is different from histology, and OCT is the mainstay of the glaucoma diagnosis. Okay, so ERG, this is the electroretinography. As we said, it measures the electrical impulses generated in the cells after light stimulus. You have to remember that in the dark state, when it's completely dark around us, in our cells, in our photoreceptors and in the Muller cells, there is a constant flux of ions. I'm not going to talk about which exactly, but there is constant flux of ions, and we have, sorry, ами може ли да седне пред 10 кабинети и аз се сега ще дойда да го започна? Добре. Окей. Добре, нека там да чака. Окей. Sorry, I have a patient waiting. So, in the dark state, we have this dark current, which is from minus 40 millivolts to minus 70. And when we have light come in the eye, the channels change. They block the flux of calcium. This leads to hyperpolarization of the cells, which generates the electric impulse. Here is a schematic of the components of the ERG and the electrical chain. Here are the, can I change it a little bit? Sorry. So this is how the waves are generated. We have rods and cones. They generate the A wave, then we have the bipolar and Muller cells, the B wave, the pigment epithelium, C wave, and of bipolar cells, which we said that only give impulses from the rods, create this tiny D wave. Okay. Here are the normal responses. So there was a commission at some point that decided to divide the ERG to several responses. We have dark adapted and light adapted responses. What types of ERG do we have? We have full field ERG, focal ERG, multifocal ERG, and pattern ERG. These are all have their specific indications, but we usually use the multifocal because it gives us the most information about the most types of cells. In congenital diseases, we have pigmentary retinitis. We talked about it. It's a disease of the rod system. Congenital stationary night blindness, which is the same but stationary. Stargardt disease, which is a macular dystrophy in children. Higgs-linked retinoschisis. This is dissolution of the retinal layers usually seen in boys, young boys. Again, it's hereditary disease. For prognosis in venous occlusion, arterial occlusion, intraocular foreign bodies, what we didn't say, I think, was that ERG helps us detect retinal toxicity. For example, hydroxychloroquine. This is a medication that became quite popular these days, and it can be detected by ERG, this toxicity, because the doses used for treating COVID-19 are exceptionally high, and in certain individuals could lead to maculopathy and decreased vision. Of course, some of the inflammatory and autoimmune diseases of the retina, especially those that pertain to the pigment epithelium, can also be detected by ERG. And ERG can give us distinction between a rod cone and cone rod dystrophies. So they are different. Some of them are predominantly in the rod system, while others are predominantly in the cone system. Okay, so here it is how the printout looks. This is a normal ERG, multifocal ERG, with a very color-coded pretty picture. We have this peak in the fovea. Here we have highest activity with not only the volts are important, but also the time it takes for the cells to react. And if you have pigmentary retinitis, for example, you have this complete lack of foveal function and loss of rod function as well. And I think that's enough. I think we mostly did what we had to do. We had some questions. I showed you some real-life patients. And if you have any questions, I have a question for you. I have to talk about corneal and scleral diseases on the 7th of May. Do you mind if we move the seminar a little bit later? Because I think I will be in the OR at least until noon.
What time would you like to have that?
Is it okay if we do it at 2 p.m.?
I think that should be fine.
Jill?
Okay, I will write in the common group to do it on the 7th at 2 p.m. the seminar about cornea and sclera.
Okay.
Thank you for your attention and good luck for now.